Sometimes you're doing the same things. A lot of people are very scared of the word morphine. Some people just can't do that. Hello, my name is Jose. I'm the Executive Director for Parentis Hospice, and this is Dr. Wielenga. He's a very experienced doctor. Do you want to tell us a little bit more about yourself? Well, I've been practicing for over 20 years. I've been sort of around the barn a lot, done a lot of emergency medicine. I'm a geriatric specialist. I've been doing hospice for probably about 15 years now. Basically went to USC, did my training at LA County Hospital. And there it's kind of like a see one, do one, teach one type of philosophy. So I was able to get a lot of exposure. So how come you got into the passion for hospice and palliative medicine? I was working for Gallatin, which is a multi-specialty group, and the Presbyterian Hospital needed a new hospice physician. I was a pretty new doctor at the time, and for some reason they picked me. At first it was very difficult because, like I said, I was ER trained, and ER you try to do everything. Hospice, it's a different type of philosophy. I mean, sometimes you're doing the same things, but for instance, if someone's dehydrated, in ER, you'd want to rehydrate them, but a hospice patient, when they're dehydrated, or anybody for that matter, it increases their pain tolerance. And sometimes it's just the opposite. So it was a little bit of an education for me.
I actually didn't know that. So if you hydrate somebody,
they feel more pain.
Oh, wow.
Yeah. So.
Yeah, because sometimes families, they ask us, can you run an IV hydration? Sometimes we do it at a TKO rate. TKO meaning to keep open, it's like a very low rate. Just we're not trying to flood them with fluids because you can also cause pulmonary edema and congestion.
Exactly.
Yeah, so I wanted to ask you, because a lot of people are very scared of the word morphine. They think, once you take morphine, you'll die. So can you give me a little bit of why we use morphine in hospice?
I can understand their philosophy. Matter of fact, we just had a patient that their family was scared of it. But one, morphine is extremely effective, and it can be titratable, so you don't have to use it at a high dose. And as long as the patient has the pain that requires morphine, there are usually very little side effects to it. And our job as a hospice physician is to control their pain. And sometimes morphine, and it comes in many different forms as well as liquid and drops. Basically, you can titrate it to where the patient's pain is controlled, but they're not having too many symptoms.
So, and then this is more of a nursing question. A lot of nurses are asking, so how do you decide as a physician how to scale up morphine? I've heard from another doctor saying that if in an hour, it peaks in an hour, if let's say 5 milligrams didn't work, then you double to 10 milligrams and you double to 20. What kind of algorithm do you use?
It depends on the situation. You usually want to, in general, all medicine, you want to start low and go slow, but if someone's having extremely active pain, then you really have to give them higher doses and be much more aggressive, but it's usually doubling the dose.
Is it better to increase the dose first or decrease the frequency, or do we?
I usually will increase the dose first and keep the frequency the same. If someone's in severe pain, I might be increasing the dose and the frequency at the same time, just to make sure they're comfortable.
Some people may say, so why do you use morphine and not, a lot of people are familiar with NORCO or Vicodin.
Sure.
So why not NORCO? Why more?
Well, sometimes NORCO or even tramadol is effective if the patient's pain is just extremely mild, but when the pain is more than, say, a 5 out of 10, many times these medicines are not going to be effective, and it's better to go to a low-dose morphine agent, or if you're looking for long-acting pain, a fentanyl patch or something to those degrees. And again, they can be titrated.
Talking about long-acting pain medication, so when do you decide, okay, so we're doing all the short-acting PRNs, or PRN meaning as needed. You don't have an order that's a frequency that's every 4 hours, but you do it in an as-needed basis. Usually it's like every 4 hours or every 6 hours as the patient starts asking for pain medication. When do you go from short-acting doses to starting on MS content or long-term?
Basically, it depends on the frequency of their pain, if it's a chronic pain or not, or just occasionally intermittent. But when the patient's giving NORCO, say, more than twice a day, or something even stronger, it's valuable to the patient and to the caregiver to give a fentanyl patch, because that's something that will work over a 3-day period, meaning that it's not
basically dependent on the person giving them the medicine. Also, when you give a PRN medicine, it takes a while to work. So say the patient's having pain and they give a medicine, it may be an hour before that pain is relieved.
You talked about fentanyl patch. So do you prefer the fentanyl as opposed to methadone, or?
To be honest, I have a little bit of experience with methadone, not that much, but I think methadone to people, it's a great medicine, especially if you're trying to get someone off of narcotics. But I think it has even more stigma than morphine does. Many people associate it with drug addiction and things like that.
I'm going to ask you something that I encounter a lot at the bedside. A lot of families say, hospice come in, they start the morphine, and my family passes. Is it the morphine that's making the patients pass?
No. The morphine's relieving their pain. It's making them more comfortable. It doesn't make people pass, only if they were to quote unquote OD. I've never had a patient OD on morphine or any other pain medicine for that matter. I mean, it's just that they become more comfortable and they transition more gracefully.
And now I've encountered this in my career, and maybe you can correct me or corroborate it. So when families decide, I have a Hispanic family, we are kind of scared. As a community, sometimes, we're scared of the word morphine and stuff like that. So I had a patient that the family wanted them to be more awake. They wanted to kind of have more interactions with the other family members. So we started the morphine because of the severe pain. Patient had cancer. And then the family said, we need to scale that back. They felt very strongly, we got to scale that back. Families are coming in and they got to talk, they want them to be awake because they were awake. We started the pain management, then they became lethargic. My thing to them was, this is probably their natural process. And it wasn't the morphine making them this lethargic. We're actually relieving the suffering. If we back off, then we're going to start to see a lot of agitation, which is what happened. You can't force the family on a treatment plan. So we started backing off, and then the patient started to become agitated. Started with trying to wiggle their feet and starting to try to take off their clothes. A lot of moaning, and then it was very hard to get the patient under control. So would you say it's true that the natural process of the body shutting down is going to occur regardless if the morphine is there or not, and taking the morphine away may actually cause them
make it worse, make the transition worse? I think what you have to understand is that we're not using morphine only when it's indicated, and the patient's agitation and pain, when it's severe enough, you're not going to be seeing the symptoms of the morphine. It's basically the patient's agitation will be, and pain will come down, and the patient's not going to have those symptoms. I like to think of it in many terms as like Ativan or Xanax when you're treating anxiety. If someone takes a Xanax, which we're all aware of for anxiety, when they're having a panic attack, it's going to bring them down to normal. If they take it when they're feeling normal, they're going to go to sleep. So morphine's the same way. If someone has severe pain, it's going to bring them down to normal. They're not going to be having as many side effects as that. But if they take it when they're not feeling pain, they're going to become lethargic. They're going to become, altered, all those different things.
Well, that's a very interesting thing. Because a lot of people think it's, you give morphine to become lethargic, but you're saying if they're having this noxious stimuli, then that's going to bring them back to baseline as opposed to straight to lethargic.
All the way.
Now, for the nurses out there, I forget. I know a lot of nurses forget, and we got to remind ourselves, when we have a narcotic, we got to think of poop. Narcotic is going to constipate you. So
40% of the time.
Yeah, so anytime you implement a narcotic, would you say that is a good idea to have a bowel management in place?
Exactly. I mean, you want to be looking at that. You also want to be looking at other things that can cause constipation of the patient if they're on iron or other agents that might constipate, calcium channel blocker, those type of things. So you have to sort of anticipate that. And a lot of times it's a good idea to start something like Senna or any other, some other agent that will help with that and get things moving before they have those symptoms. Because if they do get constipated on the morphine, one of the most painful things is when they're basically constipated, FOS, or even they can develop an ileus, which is one of the most painful things around to the patient. Yeah.
So why use Senna, not Colace, or why use Colace or Senna? Like, how would you decide?
I prefer Senna. Colace basically has more side effects, and very high doses can cause ischemic bowel, things like that.
Oh, I didn't know that. Actually.
Yeah, it's one of the side effects when you use it as a bowel prep for basically colonoscopies and things
Because
like that.
we think of cola as like a benign thing that
It is, yeah.
you just keep taking, and so it does have some side effects.
It's kind of like Tylenol. Tylenol is one of the safest drugs out there, but if you take it in extremely high doses, it can cause liver failure.
Yeah, and people just take Tylenol. So,
Exactly.
what about Miralax? When do we start Miralax as opposed to?
I use it quite a lot. I prefer it better than, say, Metamucil or things because it's a synthetic thing. It doesn't cause the gas that Metamucil can. So I use it a lot as long as the patient can tolerate it, because it has to be in a liquid form and they have to be able to drink a good amount. And
17 ounces or something.
Yeah, some people just 17 grams and you have to just put it in liquid. And some people just can't do that. So
now that we're talking about poop and bowel management, so a lot of people sometimes get kind of fixated with the bowel, and they want like a suppository every 8 days or a frequent enemas. How can this affect someone if they're just taking laxatives?
Well, I mean, the definition of constipation is not having a bowel movement every 3 days. And people who are used to having 2 or 3 bowel movements in a day basically might think of constipation as not having a bowel movement in 1 day. But people who are fixated or taking medicine, especially, I mean, you're not going to get in too much trouble if you're taking Miralax or something along those lines, or Senna. But if you're taking propellants like milk and magnesia or other suppositories, basic like fleet enemas, things like that, your body's very smart, and these agents your body's going to become very tolerant to. And one of the worst types of constipations to have is a constipation where someone is already taking these addictive supplements. They become very tolerant to them, and then nothing else works. And a lot of times I've had to do fecal disinfections because of that, which is not a fun thing for either patient or the provider.
No, I have my fair share of those.
And many times
it never is.
You're giving morphine. It's so painful. You're giving morphine prior to the disinfection, so they don't feel anything. Or feel less, I should say.
Well, thanks so much for your time, Doctor. I really appreciate you coming and then kind of giving us a little bit of insight on pain management.
Yeah, it's a fascinating thing. That's one of my favorite things, actually. So, all right, thank you so much.
Thank you.